Welcome to Conversations in Health, Global to Local. We have a fantastic speaker with us tonight, a dear friend. I was going to say old friend, but dear friend,
okay.
because we've been together. We have worked together. Dr. Edward Hilton, who is the Executive Vice President of Health Sciences here at Georgetown University. As you'll find out over the course of tonight, Ed has had quite a remarkable career. And as we try to do each week, I want you to think about his life and his career and his journey as you think about what you're planning to do with your future. One of the things there are many things distinctive about Dr. Hilton, but I think one of the most interesting things is he's been both a clinician at the highest order of working with patients day to day and leading groups of physicians in very complicated settings. He's also been the administrator of some very good-sized institutions, National Rehabilitation Hospital, and here, of course, at Georgetown. So a way to think about your career will also be, are there leadership roles in organizations that are the way that you can make a contribution? You know, when you're thinking about your North Star and you're thinking about that set of things, this is a way to also think about how, you know, this is Dr. Hilton's story will take you through many chapters, but I think that's one of the things I'd ask you to think about, because leadership of institutions is really vital, especially in the health space.
For sure.
So welcome.
Thank you. Thank you.
So we'll start with you the way we do with everybody, and so I'd like to start at the beginning. So tell us a little bit about where you grew up, and let's start there.
Okay.
So I know it's in California.
Yeah. It could. I told John this could be a single question conversation because it's a long story. But just I did grow up in California, in Sacramento, California, and basically a 1950s suburb, because I know 50s seems like who knows when that was. But just, you know, suburban life was just really sort of beginning to flourish. So I grew up in a kind of a typical suburb. Went to Catholic grammar school. Mother Catalda and Father Lynch led that school. I remember them very well. And then to public high school, on to the University of Oregon, to college. And then started to make my way east, going to Creighton University Medical School. 4 years in Omaha. Creighton was great. 4 years in Omaha was just about the right amount of time. But it was good.
Before we lose you from Oregon,
Yeah.
So when you were graduating from high school, were you interested in the sciences? Was that something that brought you to Oregon, or was that something that kind of emerged during your time there?
I think it really started in high school, but I in terms of my interest in the sciences, my interest in medicine actually preceded that.
Okay.
Or I don't know if I'd call it an interest, because as a kid, 10 years old, maybe even younger, the grown-ups would ask you the annoying question, what do you want to do when you grow up? But I always said I want to be a doctor, and I had no clear idea what that meant, obviously, but I remember feeling it, that, you know, that seems right, whatever it is. And, you know, I'm not sure if it was related to, on my father's side, was a part of the family was Quaker, and kind of serving others and so on was an important part of the conversation and so on. So whether that was kind of filtering in. So I had that mindset to the extent that you can have it at that age. And then I was very interested in the sciences. Yeah. Some that, you know, organic chemistry, and had a little of that in high school and then in college, but many people, you know, don't want to have any part of. But I liked it, I enjoyed it, and then I think the interest in, you know, again, this is kind of through the retrospective scope, but kind of rationalizing your pathway and decision. It wasn't always that thoughtful, of course. I think being interested in the sciences, particularly the biological sciences, and then thinking more, or the idea of serving others, for lack of a better way of putting it, and being connected to the world in that way, I think became more clear in my thinking. And so those two together, I think, led to the decision to go into medicine. But I see the understandable difficulty that a lot of young people have in deciding what they want to do. And I for some reason, just always wanted to be a doctor. And it wasn't a well-formed idea, I don't think, but it certainly turned out to be the case. I've never regretted the decision, of course. by any stretch.
Well, I was going to ask you, so no second thoughts and no exploration of other paths along the way. That was kind of always the road you were on?
No, yeah. I mean, I think I think I had a brief in college, my freshman year. I was so interested in the physical sciences, including literally physics and so on. I wondered about taking that pathway, but my taking college physics made me understand that probably wasn't the best thing for me. But no, I think being involved in medicine, and I think later, of course, this is jumping way ahead. But I anticipated it a little bit before it happened. It is a very unique experience to be together with a patient, and having that experience. It's just a I don't want to overdo it, but it's just a special, almost sacred experience in a certain kind of way. If you're where you're really hearing what the issues are and being in a position to do something about them. I didn't know that back when, but gradually, I guess I would say to your question, John, did I wonder about other pathways? I think it just got more and more reinforced by those kind of experiences. Right. So the kind of unformed, don't ask me this question because I have an answer, I want to be a doctor, then the sciences, and then just as I got into medical school and got into clinical care a little bit, then that just, I think, reinforced what a really special experience it is.
So as you made your journey across the continent, you stopped in Omaha, which is an unlikely spot along the way. Yeah. But tell us how you obviously knew you were on the path to be a doctor, but you decided to go to Creighton, which is a terrific medical school, but in Omaha, which is very different than Sacramento or Washington, D.C. for that.
Well, it's an interesting place. I mean, first of all, I guess I would say I did okay in college, but I was somewhat of an underachiever, and so I applied to 2 medical schools, actually 3 medical schools. Was accepted to 2 out of the 3, and one of them was Creighton. But it was, I knew that it was a good school. It also was interesting because it was a kind of a melting pot for students from both coasts. Would come to Creighton. I sort of thought of them as smart people who also had fun in college, type of thing. But I met my first person from Brooklyn, and my class in a Brooklyn accent, and all the New York kind of understanding what those communities were like in Omaha of all places. But I had a great 4 years, and Creighton was a really good school. It's interesting because one of the things we talk a lot about here at Georgetown is how to broaden the curriculum to think more about beyond acute care. And my education in medicine was literally just about taking care of patients one by one by one. There was no public health, no sense of global health. Not because I don't think the school thought it was not valuable, but it was the traditional school of medicine curriculum, which focused on the basic sciences, your first 2 years, hours and hours of lectures and so on, and then going into the clinic and into the hospital, into hospital medicine. And that's what you learned, and then choosing a residency and so on. And of course, hospital medicine can be very engaging and alluring in the sense that you can take care of pretty sick patients and stuff. But anyway, in terms of the school, I don't remember the kinds of things that we talked about later, and then we'll certainly talk about around here. So what should the medical education be, and how much more should we be able to open up the lens of students to beyond acute care, as important as that is. But anyway, we can talk more about that. But it was a pretty traditional medical education.
And that sort of that gate left an impression on you clearly, and also in contrast to what you later were involved in terms of medical education.
Yeah, no, that's right. And I think it was
social determinants of health or a global perspective were just not part of what.
It's interesting that you mentioned that, John, because we did have a group of friends of mine and I in medical school did have a sense that we weren't managing the problems that I think led to the patients being in front of us. And so we worked actually with a Jesuit priest, an African-American Jesuit priest, to start a clinic in North Omaha, which was the underserved part of Omaha. It was a clinic in which we were setting up to do vaccinations and kind of preventive medicine and so on. and the Jesuit priest was able to get the house, and we painted it and so on, and started to put preventive services in it with students and some of the attending physicians helping us out. Sort of completed that just as I was graduating, but I did inquire even 2 or 3 years later, and it was actually continuing
That's
on.
great.
So we had some sense of that,
Right.
but most of the education was not focused on that. But of course, I did my residency, internal medicine residency in New York at Harlem Hospital, and again, acute care was the dominant theme because that's what internal medicine is. But you couldn't help but, you're immersed in a community that I and many of us became very involved in, and the health disparities are so glaring and so prominent. And when I arrived at Harlem, it was in the middle of a heroin epidemic. This is in the late 60s, early 70s. And so that was just added on to a community that really had, long-standing, disproportionately poor health outcomes in many areas of the community. Obviously New York City is a mixed community in that sense. But of course, the dramatic experience that you have as you kind of realize, as you put your head up from taking care of patients one by one, is that you can ride the subway from 135th and Lenox and go to 72nd Street and Broadway or Madison Avenue, and your lifespan increases if you're in those communities very measurably, and your outcomes from many major illnesses, as we all know. But it's so dramatic to be working in a community in which they have the kind of outcomes and the issues, the determinants that lead to those outcomes, and then live in a community where it's quite different. So, and the subway metaphor to me is such a powerful one, both there and for that matter here in DC, right? From Ward 8 and Ward 7, Southeast DC to Bethesda, and the same change in outcome. But yeah, I think we lost the question.
No,
but anyway,
no. Well, I was going back to. No, I think the transit, because I was going to ask you what brought you to New York and what was that experience like, and you described some of that. I guess one question, when you came to Harlem, the Harlem of today is a little different than it was around 1970. It was the civil rights movement. It was a very volatile time, and I guess some description of how you felt, and that was in those days. My guess is that Harlem was overwhelmingly African American. So what was that experience like, coming from Sacramento to Omaha? That must have been quite a culture change.
Yeah, quite a new and different experience. And interesting about Harlem was it had changed. The Harlem of the 20s, 30s, and 40s was undergoing the Harlem Renaissance from the Great Migration, right, to New York and Chicago, and the African American community was flourishing. Still had, a lot of health issues and so on, but what happened in the 50s and 60s and 70s, particularly with the heroin epidemic and the economic issues, that seemed to dominate the community in many ways. So that's the community that I came into. But it was quite a unique time for training at Harlem Hospital or being on the faculty. Harlem is, in those years, Columbia was responsible for, had a contract with New York City for running all the medical service, recruiting the physicians and running the residency program. So that it was a Columbia-affiliated hospital. But
Columbia University.
Columbia University,
and running for all the hospitals, the public hospitals in the city, right?
Right, had an academic affiliation. NYU had Bellevue, and so on.
And just maybe one thing that's different about New York than almost every other American city was the breadth of public hospitals in that time. I don't mean to interrupt, but that's context-wise, it's very different than, say, we don't have one here at the moment.
That's right. DC General closed,
Yes,
St. Louis Public Hospital closed, Philadelphia. But New York City has always had, I think it's down to 10 acute care hospitals, but had 11 acute care hospitals and long-term facilities. In addition to that, the New York City Health and Hospitals Corporation, I think outside of the Paris Public Hospital, is the largest public hospital system in the country, and still is, so that patients could, who couldn't pay for care, could receive care. But in the late 60s and early 70s, it was also drew students for their training who were very politically involved, right? Because it was, the civil rights movement, as you point out, the Vietnam War. The joke was, but it was true, if you weren't making rounds on Saturday morning, you were down at a demonstration. And so I arrived with hair about this long, which is a different time. But it was a very interesting and committed group of both students and faculty. And in fact, Harlem, one of the things I loved about Harlem Hospital was that most of the people there really wanted to be there. It wasn't just a job; they wanted to be there and doing urban care. And certainly that was what drew the students who came there to train. It was just a very interesting, from Ivy League schools, et cetera, which is neither here nor there, but it just drew lots of different students. So it was really fascinating, a really interesting place to stay. And people remember the graduates of the training programs, particularly medicine, really felt that was an important part of their life. And there was actually a reunion about 10 years ago of the people who had trained at Harlem Hospital between 1969 and 1975. And 100 people came.
That's
it was
awesome.
quite amazing. And so it was a very rich experience for many different reasons. But it was obviously, very unique to me. And for my past, coming from Sacramento, California, or Omaha, Nebraska, it was quite different. But it was something I think was one of the most important and meaningful and experiences, professional and just life experience, of course, that I had. It was just a very, maybe oddly in a way, because it's so challenging, wonderful part of my life and career. So it was great.
When you became the medical director, ultimately, right? And do you want to say a few words about what that role entails?
Yeah. So that was a leadership role that was preceded by a couple of others. Yeah. But in fact, my first leadership role, we've talked about this, was the president of a doctors' union.
I was going to ask you when they say, tell everyone.
United Doctors of Harlem Hospital. And just, I don't know whether this is something we want to talk about, leadership and why one goes into leadership. I mean, I think, and this is, of course, through the rationalizing what you do, and it wasn't necessarily the case at the time. Thoughtful case at the time, but I sort of think of myself and others that I've seen doing the same thing as more accidental leaders, in the sense that I didn't wake up and say, I want to be chairman of a department of neurology, or I want to be president of a hospital, or president of a doctor's union for that matter. I saw people whom I trained with, particularly in neurology, who you knew that they wanted to be chair of a department. It didn't matter where, they wanted to be the chair of the department. And I think, from my perspective, and I think from others that I worked with, it became much more because of a connection with the institution, and sort of looking up from what you were doing in medicine, taking care of patients, and realizing that, there's other issues here, and that you might be able to, cliche, make a difference by being in a leadership role. And that was actually oddly, besides the fact that it was fun, why I decided I was nominated to be president of the doctors' union. This was a union that was formed by the Harlem physicians, who were Columbia faculty members at Harlem, but there was a differential in pay and sort of second-class citizens in a way, because of just the way the Columbia was organized. And so they formed a union with Columbia as the employer and the paid faculty in order to help become more competitive in bringing higher quality physicians to Harlem through competitive wages, and then also being engaged in hospital affairs to try and make a difference in the hospital. So, and that's what they did. Of course, when you're involved with a union, there are other issues that some of the faculty would bring, et cetera. But I think the major purpose was to really improve the competitive position of the faculty, and being able to recruit and also be engaged in hospital affairs. So I think it was just an example of why leadership can be kind of a potent attraction if you feel like you can make a difference. And after that, I was asked to be by a close friend who was chair of medicine, who became associate dean for the Columbia affiliation, to join him in the office as assistant dean. So I started to get involved. I've been involved as a typical teaching, attending, seeing patients, teaching medical students and residents, and taking care of patients up until that time. And you see a lot of them here at STAR Georgetown and in the Georgetown related hospitals, but was asked to do this, to work in the affiliation office, which was responsible for the medical care and so on. and he promptly stepped down. And so after I was working with him for about 6 months or so because of an issue, and so I was asked to take over as associate dean, and then combine that role with the medical director of the hospital. And the medical director is the chief medical officer for the hospital, any hospital, and so works with the hospital administration to oversee the clinical departments and the physicians who are taking care of patients. And so that gets you deep into the clinical care and the quality of the care and the credentialing of the physicians and all those areas that lead to making sure you have the right physicians, the right credentials, the right quality of care, oversight of care, and really taking care of the patients as well as you possibly can. So Harlem Hospital was a large, 800-bed hospital. In those years, you had 800-bed hospitals. Yeah. But, the length of stay, et cetera, has changed a lot, so we don't have those. But it was, obviously it's always a team sport, so to speak. But actually, that was one of the roles I was most kind of proud of in a way, right. Just to being part of that community and having a leadership role in that community, which was very, very engaging. Great need, but a big heart for sure.
Because you were in that role for how long? Maybe almost.
Yeah. So from about 15 years altogether. Yeah. But I had both roles. The senior associate dean for the Columbia affiliation. So you oversaw the Columbia's activities at Harlem Hospital, and then the medical director role. And they intersected a lot. We made the case that they should be together. If they were separate, it would be challenging. But of course, Harlem, those roles in Harlem was sort of a crucible for political engagement of three different, and not always on the same page, the city, the university, and the Harlem community. And so, besides the medical care and all of that, it turned out it was also very politically focused, or at least politically engaged. Congressman Rangel would come when there was a problem, and it was his hospital, as he put it. This is my hospital, that I use. So it was very much a political engaged in politics for good reason, because the Harlem community had many needs, and this was the hospital in Harlem, and you could, again, back to health disparities, you could walk out of the hospital a few blocks and just see the needs of the community and the impact that it had on healthcare over time, the kind of, the sustained sort of social determinants of health that ultimately lead to why people come for acute care and the need to do something about the downstream, right. or the before people get to the hospital.
And did you enjoy navigating that's a pretty complicated set of arrangements to navigate the politics of a community, the politics of Charlie Rangel was a very powerful member of Congress from New York City, lived in Harlem for many years, and then the data. 800 beds is no small thing. So how did you? That's a lot to navigate. Was that? Fun is not the right adjective, but was it rewarding? Were you able to feel like you were able to move the ball when you were?
I think so, but I'd say I think so because it was just to be, to make sure it's not all, just a lot of fun, as you put it. It was challenging. The politics meant that if there was a problem at the hospital, the city's first reaction was to blame the university. The politicians sometimes had the same reaction because Columbia wasn't doing its job. A patient care issue had occurred and so on. So you were sort of in the middle of that. And public health care is underfunded, basically. It just is. And New York City was no exception. Columbia had a contract for, when I started, it was $50 million. And in those years, that was a lot more than it is now. By the time I finished, it was about $35 million. And that was because the city just kept, trying to find ways to economize because of various city funding issues. And Columbia was a strongish advocate, but there are other priorities that they had as well, as you know, in city politics. So I loved the hospital. I loved the people I worked with. I felt like I made a difference, which was why you wanted to have leadership roles, obviously. But it was frustrating. It was one of the most challenging roles I've had for sure. So there was all of that, and I think that's what, I think making a difference in leadership does come with it if you really, because it requires sustained attention, working through complexity, a disposition, I guess I would say, of patience and sustained attention and effort. Not that I was good at that necessarily, but it certainly required that, and other leadership roles as well. So I think there's something to extrapolate from, even at the extreme, right? That this was in many ways.
But on the one hand, you were making it an impact through leadership of an institution, but you were still seeing patients in those days.
Yeah.
So we didn't talk. You chose to become a specialist in neurology. So maybe a little bit about that and what was attractive to, because those are two very different jobs to have at the same time.
Yeah. Well, I went into neurology because I think we mentioned that I love the neurosciences and so on. And I also had, as I'm sure that the students here have had, the experience of having a really great teacher and that makes a big difference in your interest in, to say the obvious, in a there. And those happen to line up 2 or 3 different times with neurology and the neurosciences. So I love neurology and going into it. Briefly toyed with psychiatry, but chose neurology. But there's also a coincidence with the impact in a community. So stroke is the second leading cause, second or third, depending on what leading cause of death, and certainly the first leading cause of morbidity. In a community like Harlem, just as an example, where hypertension, heart failure, and so on are so common, stroke was a major issue, as well as other neurological conditions. And so when I first got to Harlem, this is totally a side thing, because of the heroin epidemic was so prominent, and needle injection and needles going into places that were the equivalent of puncture wounds. Tetanus which you don't see now, was not infrequent, which was a very dramatic disease that vaccination would prevent. So there was some real work to do in many of the areas of the neurologic conditions that would show up in the hospital. But I think the role of and this combines academics, teaching, and patient care was really attractive, and that was my sort of initial role. So I finished my residency, came back to Harlem from Columbia, and stayed and was in the Department of Neurology and worked closely with I still know, and just had dinner with a person who was chair of neurology in those years, who's still making rounds now at Columbia. And so I just had all of that was very engaging, but also made you want, as I said earlier, if you looked around you, to try and do something to kind of improve the working conditions and so on that I experienced. And so I continued on seeing patients. It was also important, if you're a leader, to have folks you're leading not feel like you're isolated from what they're experiencing, to say the obvious. And so that was, I think I enjoy patient care, but that was another reason, if you're the medical director of a hospital, to know what the faculty are experiencing, and to be able to help. That helps shape your priorities, but it also gives you credibility that you understand the working conditions that the other physicians are engaged in. So I thought that I wanted to still take care of patients in the clinic. Largely, I didn't do acute care when I was in those leadership roles as much. That's pretty demanding. I could do a clinic a couple of days a week
for a fixed period of time, right?
Yeah.
But you were still interacting with patients.
Yes. Yeah.
So there was a whole. You could have had an amazing career just in New York, but then you came down to D.C. and I guess a little bit about your work at the National Rehabilitation Hospital, but also with Georgetown in those days too. I'd love to kind of take us forward.
I think maybe that just another example of because I had leadership roles when I came to New York, of the institution making a big difference. Well, we came to New York because my wife had the opportunity, Cheryl, to to take over as the president of the Legacy Foundation, which was dedicated to reducing smoking in youth, tobacco use in youth. It was founded through the Master Settlement Agreement with the states that led to a lot of healthcare funding going to the states. But it also created the Legacy Foundation with one of the largest budgets that you'd ever want to have, actually, to develop a public education campaign directed toward youth and so on. So Cheryl was in public health at Columbia, where we met, and this was an opportunity, and so I dusted off my CV and looked for a job. I had a common friend with a person who's the founder and CEO of the National Rehabilitation Hospital here in Washington, D.C., Ed Ekanoff. Very inspiring person who is paraplegic, but just straight ahead, was a football player, had a car accident, became paraplegic, but golfed, did everything that you can imagine, and so we had a common friend who recommended me to see Ed, and I was recruited to be the medical director at the National Rehab Hospital, and I had relatively my contact with rehabilitation was obviously as a neurologist. You refer patients for stroke rehabilitation or otherwise, but I'd never really been immersed in the world of rehabilitation medicine, which is quite incredible. The kind of the work that is done, particularly in a hospital setting, patients who have a spinal cord injury, or when you wake up one morning and that evening you've been in an accident, and you have spinal cord injury and have severe neurological injury, and so as an example, and so that's a world of caring and rebuilding lives, very, very much so, and so I had not really been immersed in that, and I just had a wonderful experience there.
Interesting.
And that, that was a joy to be the medical director and vice president for medical affairs, which is the equivalent of a medical director at the National Rehabilitation Hospital, which brought me to Georgetown because just a couple of years before, we came here in 2001, 2002, and that was around the time that MedStar Health System purchased Georgetown University Hospital, and so Georgetown became part of became the academic partner of the health system, and so that brought me to Georgetown as a Georgetown faculty member.
Because NRH was part of that.
It was part of MedStar Health, right? So it's the rehabilitation hospital for the MedStar Health System, which is now the largest health system in the Mid-Atlantic, one of the largest in the country. So it's quite an important health system. But it also, speaking of why you want to be involved in leadership in a particular organization, it's a not-for-profit health system that obviously needs to make sure that it makes a good bottom line to be able to reinvest, doesn't have shareholders, but also is a very value-centered health system. And really, it's interesting. They're also have gotten very involved in health disparities work and so on. So I felt very fortunate and wanted to stay involved in a leadership role. That got me involved with Georgetown. I was asked to be chair of the Department of Neurology and the VPMA at NRH for a while, and then just the chair of neurology. Okay. And then 8 years ago, President Joe asked me to do this job for a couple of years at the time, and here we are 8 years later. But,
do you describe what this job is a little bit, Ed? So what is it? Because all of our students here, almost everybody here is a student on the main campus,
so,
and everything we're going to talk about is
we need to make sure they know
exactly
what the medical center is about, right?
This is what's behind the curtain.
Yeah, that's right. So I'll invite you over.
Say a little bit more. Yeah, don't know that.
Well, so it's the Georgetown, as you probably know, in terms of the leadership, it's organized into 3 campuses, and the leaders of those campuses report to the president. So there's the Law Center. Bill Trina is the vice president, senior vice president, or executive vice president for the Law Center. The down campus, so-called main campus, and Bob Groves is the EVP, provost, and then the health sciences, the medical center, which is really the health sciences campus. So the School of Medicine, now the School of Health, very good. School of Nursing was reestablished. We've had a nursing school since 1910, but it had been combined with other health studies to become nursing and health studies, and now separated those. So 3 health-related schools now. Then graduate education through the biomedical graduate education set of programs, 20 masters or programs, so 8 PhD programs. And then the Cancer Center, the Lombardi Comprehensive Cancer Center, which is its own kind of entity, and the basic science departments that support both research and teaching in the School of Medicine and others. So it's a large domain with a significant budget and so on. But it's a health-focused education and research programs for the university. And so I had no idea how to lead such a thing, to tell you the truth, because it was just such a unique. But I had good colleagues and just great person to report to and so on. So it just was a very special experience as well. And Georgetown values are, I think, lived as much as we can. They're very alive and well and visible. Not every day and every moment, but it's, that's another big draw for this job. So again, I think the institution was important in wanting to and enjoying getting up every day and going to a leadership position. Not so much the role, although but what is connected to. I think that to me, that's I don't think there's a way to say better, but it's a more fulfilling way to approach leadership. I would say I'm I guess biased because I just was fortunate, have been fortunate to have those opportunities to connect with institutions that you want to, be leader if you have the opportunity of. So.
Well, and you certainly impacted I'll just say to all of you that Dr. Hilton's leadership has profoundly affected our direction in the health sciences over the last 8 years. I know you signed on for 2 and then stayed for 8, but you've really helped I think set us on a really important strategic direction. And so some of the reading that some of the students read a little bit about Victor Zhao's piece about the future of academic health centers and a little bit about the HSSI and the Health Sciences Strategy Initiative here at Georgetown. I guess I hear why you found this fulfilling and meaningful. I guess everybody here that's going to do health is going to be doing it in the future. I think this has been a time of real change in health education and health research. And I guess I'd invite you to reflect, where do you think we're going? And how do you see, especially from a place like Georgetown, institution with Jesuit values, but also we've got to compete in a world that's rapidly changing. The sciences are changing, biological sciences are in a revolution. Just your thoughts about what's the role of an academic institution like ours in this?
That's a really good question. But before I answer that, I want to make sure that the students know how important your role has been in all the work that I've done. We've done incredible work together. And truly, and I don't mean to point, that's one of my bad habits, but in many ways, certainly the global health world, for sure, domain has been just invaluable and, of course, a great pleasure. It's interesting because on the one hand, we should be, I think, focused on things that are important and reflect Georgetown's values that take you, the Cure Personalis is a very important short summary of values that are, I think, particularly focused on health. But it's care of the whole person, but when you think about what that means, it's care of the whole person in all their dimensions and care of the whole person in their community. And so it takes you out into the world, right? For sure. And so we should be doing as much of that as we can as a university. What is the role of the university in making a difference in health? And so I think, maybe examples are the best way to show that. And a couple of them are, and they get to interdisciplinary work, working together and bringing parts of the university together. I think one of the most effective of those, and I think the long-term important, is the Health Justice Alliance, which is a partnership between the Law Center and the Medical Center, and largely focused on back to the social determinants of health, so many of which have less to do with medicine than heart failure or asthma, those kinds of things, other than, but more what social issues are either causing them or exacerbating them. Asthma is a good example because the environment can be so important. Employment, healthcare coverage are so much more effectively dealt with by partnership with lawyers and doctors, and I think that's been a very important example of what the university can do, bringing healthcare, the combined impact of lawyers and doctors, And we just had statistics that have now come forward from an incredible example of that. So part of that, there's, maternal mortality is terrible in Southeast, Central Harlem, and so on. Morbidity, mortality, health, maternal and child health. And a partnership that's involved, it's called Safe Babies, Safe Moms, funding by the Clark Foundation, but brings together multiple health medical disciplines, the Health Justice Alliance, McCourt
Which you all
School.
read about.
Yeah, and so that's the application of the work that the Health Justice Alliance does. McCourt School of Public Policy focused on how do you make this program sustainable and translate into policy. But the work of the combined effort has led to the statistics that we're seeing not only close the gap between African American women and white women, but women who are involved in this program appear to do better. So it's not only closed the gap, but it's improved outcome. And which of those, there is a research component of this, so we're trying to understand what happened here. But certainly addressing in a structured way, in a very committed way, the social issues and social determinants of health, and those that really lead to health disparities and make it very hard to achieve health equity are part of that. And so, but that's not, so that's important for Georgetown, for sure, and that's important for I think for all of us. But you mentioned the biomedical sciences are changing rapidly, and how do you keep up with that? And the other mission, of course, at the university is research. And we're a research-intensive Carnegie Institute-rated university. A big chunk of that occurs in the Health Sciences Center, the Medical Center, in the basic science laboratories. How do you not try to do everything, but choose priority areas and invest in those, especially when basic science research costs money. You have to, overhead and so on, not to get too far into that, but means that a university has to find ways to cross-subsidize that work. And if you really want to stay as a leader in academics, particularly in research, that's another part of what we need to be doing. So that's a challenge. It's really what I think we're trying to find our way. And I think what that means, and Bob Gross says this a lot better than I do, we're a relatively small university, so we shouldn't have two of things necessarily. So let's bring the departments, the chemistry departments together, the health sciences campus and the down campus, and find ways to collaborate. That's the meeting I was just at. There was a report of the follow-on report of the Sciences at Georgetown Task Force, which was co-chaired by the Dean of the College, Rosie Ciballo, and the Vice President for Faculty and Academic Affairs at the Medical Center, Elliot Crook, bringing leadership of the sciences on those two campuses together to think about ways we can do things together and leverage our strengths, and therefore whatever investments we're able to make will be a lot more effective. And so that's, I think, what Georgetown does well and can do very well to keep both research and education moving forward using the strengths that we have, but understanding we don't necessarily have the endowments, that we don't want to be Harvard or Hopkins, frankly, but we also don't have the money that they have, but where there's lots of other things we can do as a university. So I think both fronts, but they're kind of, and that of course brings you to the spectrum of, and Victor uses this analogy, molecules to a community, so basic science work translated into impact that then eventually affects the communities that we serve, and then, speaking of McCourt, policies that can have a lasting impact and keep those changes sort of in place, so to speak, for those that are amenable to that kind of implementation. So that's what the university can do, I think, really well too, is to keep your eye on that, and that's what I think the point that you made. But Victor's kind of charged to us. That's the spectrum of work that we should be thinking about, and connect those dots to bring, the cliche is the bench to the bedside, but really, molecules to society means you take the work that you're doing to creating new knowledge and bring it to the people, so to speak, or out into the community. Yeah.
Well, that's the perfect pit. The reason I'm really glad you spent some time on that, and I'm going to ask Naomi to kick us off with the student questions, but I guess I want you all to reflect on what Dr. Hilton said. You know, a way to think about your place along the continuum from molecules to society, like one place is to be in a lab discovering something brand new. The other is to be in a community doing organizing or public health outreach, and there's a bunch of different places in between. An institutional role, though, helps think, how do we make the right decision along that whole continuum about how our institution can make a difference, right? And you know, that's what you've done for the last 8 years, to guide how Georgetown maximizes its impact. And I think, so again, when you're thinking down the road, that's a role for leadership, is to lead people, because people need leadership to get things done, but it's also to strike that sort of strategic focus. So
Yeah.
thank you.
No, and I just would add, the only other thing is to find partnerships. I think what's been important for Georgetown is partnerships. And for example, with the health system, with MedStar Health in many ways, the translation of our work, our discoveries, if you will, or others, into clinical trials and translational medicine is a very important way to bring that, to work through that continuum, and really taking advantage of having a health system partner or other partners is an important way to really leverage the strengths we have. Yeah.
Absolutely. And partnerships don't happen by accident. They happen because you try to put them together.
That's right. They're intentional.
Exactly.
Right, for sure.
Naomi, do you want to kick us off?
Sure thing.
Now, we had softballs here, so keep it up here.
Well, thank you so much. I wrote down a lot of questions. It's a little hard to narrow it down, but I might draw on kind of that last point about bench to bedside to population, because I think typically when people think about medicine and doctors, they think about a doctor interacting with a single patient at the bedside. But then with this paradigm of molecules to society, it feels like the bedside is kind of lost from that. So do you think that historically there's been too much of an emphasis on bedside? And looking ahead to the future, do you think that might be de-emphasized, maybe even disappearing completely?
Yeah, well, no, I don't think it should disappear, but I take your point, and I think it has been overemphasized. And I sort of mentioned my, which is back in the dark ages, but my medical training, you wouldn't have known the word public health, just didn't appear, et cetera, or social determinants of health, or those kinds of things. And I mean, part of it is, it is. I mentioned, I didn't want to overdo it, but being in the position to take care of patients one by one is very engaging, and it's just a very special experience that you may not look up from and say, gee, but there's other things we should be doing here. But that's not the question, really. The question is we don't have to stop doing that. We train physicians or nurses or healthcare providers of other types to see patients. But speaking of continuums, it should be in the continuum of how do we make a difference in the health of one by one. Yes, that's still important. We want to keep up and train doctors and nurses and others to be able to take care of patients. But to also either have the perspective themselves or make sure that we're placing that in the context of the molecules to society, really, the larger picture. So I think it should change. I think it is changing. I think here at Georgetown it's changing. But curriculum is hard to change, and because there's also tradition and other sense that faculty feel that we must teach these things to create doctors or nurses. So there's it's not easy, but it is changing, and I think the broader perspective is starting to become more part of the thought process. And the medical students here and the nursing students are very interested in that. There's an opportunity for medical students, just using medical students for the moment, to work in a health justice track, and they have an opportunity to go, especially in their clinical years, to a clinical setting in which they're working side by side with law students and law faculty and attendings and so on, in a clinic setting in an underserved area, and it's one of the most popular experiences in addition to the curriculum that students can have. So creating those opportunities, giving that perspective, is really important. Georgetown is doing that, and there's a whole bunch of other work going on. There's a large health equity. How would you say it? It's grant funded, but it also has multiple other parts focused on health equity education. So when you think of what should students of any sort, in health at least, come away from Georgetown with an understanding of, combine that with Georgetown's values, shouldn't it be concepts of health equity and what we're talking about now, that you do understand whether you work in that area or not, that one of the most difficult to address so far, and one of the really most important injustices, is the difference in health outcomes. There's no reason, really. I mean, there are many reasons, but when you think about it, there shouldn't be reasons why what we just said about the subway ride, right? That just shouldn't happen. And how do we make a difference in doing that? And so that needs to be part of everyone's, whether you are directly involved or not, but having an understanding, because there are other ways that you can make a difference in for your votes or the life that you lead. So that should, and I mentioned that because that's part of the work that a number of people in the Health Medical Center, Michelle Road and others, is focused on health equity and health equity education. It's also in partnership with MedStar faculty and attendings and so on. So that's can be the common denominator potentially for everyone who graduates from a health-related discipline in Georgetown. So that's another way that we can change the curriculum and the educational experience. And it is changing. We need to continue to push that. Can't lose how do you take care of individual patients for sure, but everyone I think who graduates from health education in Georgetown, nursing, School of Health, School of Medicine, should have that perspective. It's the larger context that we're working in one way or another. So I think we're getting there. It is also important to think about interdisciplinary work, so that doctors and nurses aren't working and other healthcare professionals so in such an isolated way. We're trying to do that. And so there's lots of ways we can change the paradigm, but it comes a little slowly sometimes. But really important question.
Thanks, Alan. Ethan, do you want?
Yeah, I mean, you've been such an effective leader over the past however many years you've been in the healthcare
Thank you for that.
industry. But I was wondering, what qualities do you think was able to differentiate you and allow you to create change in the healthcare industry? And what do you think are the skills that healthcare leaders need today?
Good question. It's always hard to kind of answer what does it take to be a good leader. I think having a perspective that is kind of beyond just your immediate area of influence, being able to, I think it is about being able to create partnerships and engage other leaders and other important constituencies that you're working with. I think it's kind of silly, but being a good listener and being trying to sort of dominate and be able to really understand and truly hear what the folks that you're working with and trying to accomplish change are about. I think it's also forming and frankly enjoying forming partnerships that you like working with other leaders or other constituencies as you engage a common goal and a common good. But that being part of the way you approach your leadership role. I think picking an institution or a leadership setting that engages you deeply, because then you care about the outcome, right? I mean, leadership in its own right can be really exciting and interesting and so on. I think caring about the institution that you're helping to lead, maybe it seems obvious, because why would you be a leader in some place you didn't care about? But I think actually really wanting the institution to succeed, caring about it, what its mission is, and so on. Again, maybe it's obvious, but it's so important in being a successful and frankly having fulfillment as a leader, I would say, are some of the things that are important. I think, again, some of the things we already talked about, and kind of being aware of the larger issues. And in healthcare, the taking care of individuals is important, but the bigger picture of what we've been talking about here is really important in being an effective leader. Global health, the same idea, for sure. All these issues are very important in a global dimension, And I think that the title here is global to local. You can apply, that's a continuum in and of itself, right? Back and forth, and we've seen that in some of the work that John's helped lead, developing our global health programs, the applications back and forth, right?
I really do think the healthcare is a horizontal activity. You know, I mean, what global to local implies sometimes a vertical sense, but I really do believe that you're seeing more and more people in the world wanting to collaborate, because while context is different, you got to always be sensitive to context and not import your context to someone else's.
Well, that's right.
But there's so much to share in learning, and I think leaders that situate their experience in a larger global context, or you know, as Dr. Hilton does, like that's how you mobilize. That's a way that you motivate people.
Yeah, that's right. Give them a bigger picture within which they're working, and be able to articulate that, and why that's important, and what the values are that that are embedded in that work. I think makes a big difference. And sometimes we just forget. Leadership can be so engaging the day to day. What's the current crisis that's coming in the door? And someone gave me, I don't follow this frankly, but good advice to say, you have to deal with those things, but keep in front of you what are the specific goals that you want to achieve, and why you're doing it. What's the point, right? Why are you a leader? You know, and get paid a little bit more maybe, et cetera. But that's not the point. So anyway, those are a little intangible, but I think at least some of the thoughts I would have in what John has said.
Yeah, well, I think listening and communicating are your strengths in many ways to move it. So I think those may seem intangible, but I think they're essential to
Tell my wife that.
I will do, exactly. I'll pass that along.
Yeah, thank you tonight.
So one of my questions is, you've talked a lot about how medical education has changed a lot since you were in med school to now. And I'm curious where it's still lacking in your opinion, either at Georgetown or generally. And like what changes have been most difficult, and what do you foresee as being most difficult?
Yeah, I just think it's a good question, because we want to understand that in order to make the change in the education. And I think it applies to nursing and to other health professions as well. I don't want to be too medicine-centric. But just as to the medical curriculum, I think, first of all, the body of knowledge that you need to learn to be a doctor, a nurse, or other healthcare professional just keeps growing. And of course, with that comes specialization. So you kind of go back to a somewhat smaller body of knowledge. That's growing as well when you choose a specialty, if you do. And so just the fundamental core education that needs to happen, or at least folks feel needs to happen. I think there's probably a thought process there that could say, well, maybe certain things are not, that we learn in the first 2 years of whatever education could be done in a different way, or maybe we don't need to do that. So curriculum is very hard to change, partly because there's so much of it and it's growing, and it can be very, very traditional. So I think leadership is going to be really important in changing how we educate our healthcare professionals. And yes, there's a body of knowledge, and we're doing that more. And the medical school, just speaking of the medical school here again, and nursing does as well, and health, but has added specific tracks that can channel students beyond just the sort of the acute care education that they have. But there's also the teachers are focused on their subjects, and so it's just the net of all of that, the large amount that needs to be taught. The faculty who are doing the teaching are invested in, feel that they're important subjects and so on. It's hard to describe, I guess, but it's hard to say, okay, now we're going to stop doing X and add Y. But there is that thought going on, that process going on, and I think leadership of the school and leadership of the health sciences are really important in making that happen. And we'll have better healthcare providers. And a more of a focus on, again, ultimately, you want to make sure people have good doctors and nurses, et cetera. But boy, the difference in the long run in community health is about the other things, for sure. I'm not sure if I answered the question, but there's some version of that.
Kayla?
Hey, Kayla.
In hearing you reflect on some of your previous experiences and time at Georgetown, a lot of your values come through, like science within impact focus, equity, improving healthcare outcomes. But I was curious, in your own words, because you've had so many varied experiences with different responsibilities, what's been the through line for you throughout all of these different career experiences? And are there any paths that you wish you had explored or taken in hindsight?
It's a good question. The latter question I haven't really thought very much about, I guess. But it's always important. And I could say something very negative, and time's running out, but I won't say to make changes. I think what's been kind of the consistent sort of rationale or thought process in leadership. I think for me, I love medicine and I love and the broad scope of medicine. So it's always been, I love neurology, and so the nuts and bolts of healthcare that I'm involved with or helping to oversee, I've really cared about just as a discipline. Of course, that's helpful for sure. And then I've just been really fortunate, again, not to make it all about me, trying to extrapolate to the question, but if this can be extrapolated. I came to Harlem Hospital, the Harlem community, because I wanted to be involved in urban health and had some vague idea of that I could, go to a place where I could make a difference. But I came to be so engaged and feel so fortunate to be in the Harlem community and to be working at Harlem Hospital and to have the people that I was able to work with as my colleagues and many of them as friends. And so the institutional connection really motivates you and wants you to spend more time doing X, Y, and Z. And I was very worried when I came to Washington. We moved for a good reason, a very important reason. But I was fortunate to find maybe not that same connection and the kind of depth that I felt, partly because that was my first healthcare experience and stuff. I found it here, interestingly, at the rehabilitation hospital, the people that I was working with and the engagement they had in making a difference in the lives of people, many of whom had very significant, impairments that changed their lives. And then coming to Georgetown, the Georgetown values are front and center, and lots of warts and lots of crabby people and stuff sometimes. But I just felt really fortunate to be engaged in and want to get up every day and go to work, which I do. And so that alignment of institutional engagement and caring about the institution and how much it made a difference for me, because it changed my life in many ways. I feel really fortunate having that succeedingly happen in each of the places that I worked and were engaged in. So I guess that's a through line of sorts. And I'm not sure what I wished I would have done differently. I really liked kind of the easiest part of my career, again, not to focus too much on me, but was the academic life of a clinical attending who's on an academic medical center, seeing patients, and at Harlem, especially the hospital-based care is, there's a lot of very sick people there, unfortunately. But teaching medical students and residents and others, and then clinical research. I did some clinical research, and that, feeling like you're expanding the knowledge at least a little bit. That was in some ways, it was very engaging. When I think of the complexity of the challenges and so on, it was one of the in some ways easiest time in my professional career, but a very, very multifaceted one. So I guess maybe there's something there that, to the extent that you want to stay involved in academics, adding academics into healthcare really can be very satisfying, of course, and teaching and so on, as John is doing. So there may be something there that at least partially answers the question.
Anna?
Yeah, so you talked a lot about how medical education has changed. So I'm sort of wondering, are there institutions that Georgetown has taken sort of inspiration from in terms of advancing, or is there different things in your career that have sort of like been catalyst moments that have led you to sort of inspire change in how medical education is changing?
Yeah. First part, Georgetown, I think we're, I can't name an institution necessarily that is a model, but for example, in some of the specific work that we're doing in the Health Justice Alliance, there are colleagues in other institutions that we learn a lot from, and so on. That doesn't exactly answer your question, but certainly being out and engaged with people who are doing similar work. And the second part of your question, do you want to just say that again?
Yeah. I think, was there a moment that sort of helped be a catalyst for your ideas of changing medical education?
Yeah, I think it was my own personal experience being very involved in acute medical care. In a place like Harlem, it's hard not to be. I mean, it's so important, and so it just absorbs you in a way that was very special for me, at least, and for many. But then looking outside, just kind of, I sort of picture as kind of looking up from taking care of patients to what preceded the reason why they got to the hospital, right? And all the social issues and the community issues. Understanding the dimensions of that. A colleague of mine wrote a paper that was in the Perspectives in the New England Journal of Medicine in the mid-'80s about excess mortality in Central Harlem. So that men between the ages of 40 and 60 roughly had the same mortality rates as their counterparts in Bangladesh. And so writing about what we were experiencing, others writing about what we were experiencing day to day, and then really understanding that and what that meant and how different it was when I got on the number 2 train and went to Greenwich Village, where I lived, in terms of healthcare outcomes. I think that I come back to that metaphor because I realized it, and I think that made a huge difference in thinking about what perhaps I could be involved in and help trying to make the Harlem Hospital and Harlem community experience a different. I didn't do a lot, but facilitated what other people were doing, and that's leadership then, I guess, right? That's where leadership can have such a huge impact, is that you help make it possible for others to make a difference, really. And so I think that's when that perspective really made me understand what maybe I could do to help, but also how important that is. And its numbers are not hugely different now than they were then. We've made a difference, but anyway, there's a lot of work to do, I guess what I would say.
You want to jump?
Yeah, I have a question. So you talked about the importance of medical education, and I like the statement you said earlier, make it possible so others can make a difference. And in global health, we talk about capacity building.
Right.
So I was wondering, there is a tendency of people that is able to come to Georgetown coming from very specific socioeconomic and backgrounds. And I think having a collective and diverse perspective is really crucial in becoming a leader because you're listening
Yes.
from all different things. Has there been any, especially for first generations, has there been any efforts from like the medical school or so in collaboration with other schools kind of creating an environment that is more attainable for those who are first generations backgrounds that doesn't have necessarily the typical socioeconomic advantages and backgrounds?
No, huge, very important question. I would say we have not done a good job on that, and we just haven't. Not that we haven't considered it and are working to do that, but if you look at the School of Medicine class did increase the number of underrepresented students, just as a category. 3 years ago, nearly doubled, and the part of that was financial support. We invested more and so on. It hasn't been necessarily sustained, and I think we're still more than we were. It became close to a third of the class. Not as diverse even in the third as I think is important. The other part of that, of course, is what's the environment that you're recruiting the students into? And is that inclusive? Is that, really welcome them? And do the students feel comfortable and like they're not just recruited because they want to be, number 5 of the underrepresented students? And that's something that takes a lot of reflection on the part of an institution. And I would say, for me, what helped me understand what we're not doing and what kind of structural racism, frankly, or at least implicit, maybe explicit bias sometimes, is present in Georgetown. It's not out there, which is what I felt it was. It's in here. Was after the murder of George Floyd and the focus on those issues and what we still needed to do and what was present here among us was really important. And that gets to, the idea of trying to be as inclusive in the students that you admit, and then creating an inclusive environment here. And we have many issues. I mean, we still evaluate students in a way that reflects implicit bias. We've had to go to a pass-fail third-year grading system because that became clear. And we learned that as we focused on that after the murder of George Floyd. We should have, I don't know whether we knew it a little bit before, I don't know, I didn't. And we should have, shouldn't take that intense spotlight to help us say, well, wait a minute now. We noticed that in the Alpha Omega Alpha Society, which is the honor society, we had one underrepresented student admitted over the 3 or 4 years. What's that about? Why? So then you go back to grading and evaluation is how they're evaluated. So was that biased? And it turns out it was. And so, that's just all by way of saying it's very much on the minds of our minds, or however you want to characterize what the thought process is, and there's steps being taken. And we've tried to take the opportunity for implicit bias in grading out of the picture by pass-fail, while we try and work on the issues that led to that. So no, I think both in the admission process and then in the environment that the students and faculty, for that matter, go into. A lot of committed faculty. I mean, the faculty, a number of leaders are working very hard on those issues on their own initiative, and a number of instances. Then the structured leadership is as well. But there's a lot to do. So it's a really continued and important question.
And all I would add is, I first came here about 45 years ago, and in Georgetown's changed as an institution quite a bit.
Mm-hmm.
This is a very different class than the one I was in as an undergraduate. Having said that, I do think change takes time, and change won't happen by accident. And I think we are a long way from first-generation students or students who otherwise feel left out or left behind feeling central to what this place is. Because frankly, they weren't in the history of the university. Mm-hmm. And so we've got ways to go. Mm-hmm. So that's a great question. Leo?
All right. Thank you so much for all of that. I found the acknowledgement that Georgetown has some stuff to work on as far as like the DEI and underrepresented students to be very refreshing coming from someone in such a high position of leadership. I do want to shift gears just a little bit though. As a School of Health student, one of the things that I've noticed is I've loved my time in the global health department. I love the people. It's been an amazing experience, but I do think that the School of Health is still trying to find its niche and still trying to find its role on campus. You mentioned the interplay between like the School of Medicine and the law school and with like the Health Justice Alliance, and the partnerships with the McCourt School of Public Policy on how to take the medical developments out
right.
to the policy level. And so where do you think the School of Health fits in among this tapestry? Where do you think the School of Health can best make its impact?
Well, and John, who was a very important part, John was the dean of
the
School of Nursing and Health Studies when these two schools were formed, and can certainly comment and give a better answer than I can probably. But the one of the rationales for the School of Health, one of the sort of goals for the School of Health was to be interdisciplinarily connected to the rest of the university. And so that was a very explicit part of the formation of the school and the rationale for the formation of the school. And so what Dr. King is looking at and working on is just that, so that there are establishing more connections with the Law Center is one, working on connections with the school or the environmental, that's now an institute, I guess, not yet a school, but environment and health.
Earth Commons.
The Earth Commons. Business, Dean Almeida has reached out and is working with Christopher in establishing the business of, so interdisciplinary work, connecting with MedStar. We just, a master's program in executive quality, safety, and leadership that's taught by MedStar faculty is coming into this School of Health. We were just talking with Christopher about how to approach Dean Sens as the Graduate School of Arts and Sciences. That was a meeting today as well. Become something else, and the graduate programs need to find homes. What should go to the School of Health? And there are several that are really important, including global health as a master's that should come to the Department of Global Health and bring with it faculty who have appointments, not necessarily leaving where they are, but have appointments in the school. So coming together as and engaging other areas of the university is very much part of what the tapestry of what the school should be, and that's very much a work in progress. So within the university itself, with our health system part, there's a lot that the School of Health can do with the health system, and the health system is very interested in being involved more, being engaged in the faculty and so on. And so I think that's front and center in what Dr. King's vision of the school is as he builds the community that is in the school, that is the school now, very much, and it's a new school, so there was work to do there, and I think he's, so far as I can tell, has done a really good job of that. And now, how do we engage the larger issues? But John, you were very involved.
No, I mean, I think I agree with everything you said. I think, Leo, one of the challenges of starting something new is that it's new, and that means that you can't. It hasn't reached its full potential. That doesn't mean that what it's doing isn't incredibly meaningful and rewarding, because you've got three degrees. We'll soon have a fourth undergraduate degree that are all anchored in, a deep faculty, committed students, many years of history. But I think the real bet on the school, as Dr. Hilton said, is what it could be. Not to get sort of into the mechanics of universities, but universities, if you think about it, are a collection of really deep people who are experts. I mean, the people you take classes with are world-class experts, usually in a particularly defined space. Health, by definition, is more than that, right? Whatever it is more than molecules. It's even more than public health, right? So if this school is going to be this anchor, it's going to do a lot more things. It's going to partner with others. And I think, to be honest, the history of universities is that universities have not done that work especially well. I don't think that's a huge overstatement.
No.
But I don't know any university that's serious that isn't trying to figure this out. So among the ways we're trying to figure out, how do you take the problems of the world, which are truly interdisciplinary, climate change, migration, fill in the blank, whatever it is, what mechanisms are going to make it more likely that you bring the intellectual firepower of a university to bear across disciplines to answering the problem the world has right now? And so this school is a bet that this is a way to do that. But it's a bet in progress. So you're part of something that's going to be big.
Yeah, it's very exciting. And in Georgetown, we're fortunate, I think, in terms of just the breaking down the silos and bringing, programs and schools together and interdisciplinary work and so on. It's supported very much at the leadership level. So President DeGioia very much supports this. The board gets very excited, the university board, when we talk about this kind of work. They really do see that as what the university should be doing and are supportive of it. The rest of the leadership, the provost and the dean of the law center, are very supportive. Faculty are, but they also have their own worlds, right? So, you have to facilitate and help folks see why this can be important both to them and to the larger university. So, but it's a really great moment for the School of Health. I think there's a lot of potential when whatever else you do, and you come back as an alumnus, so.
hold us accountable.
Yeah, please.
We're coming close to the end of our time, so I thought I would just ask everybody to join me in a round of applause for Dr. Hilton. Thank you very much. This is all.